My name is Simon Hanft. I'm a brain tumor surgeon here at Westchester Medical Center. And what I have for you today is Connectome of the Week. And in particular, we have a case of a 72-year-old male with a left-sided dominant insular glioma. What you can see here is the preoperative flare, which we have displayed in the Quicktome software. And what I want to emphasize initially is that when you are loading this scan into the Quicktome, ultimately when it's displayed, the software will have the networks of interest immediately displayed for you to click on, display and visualize, and obviously begin to probe and understand their relationship to the tumor. So why I think that's critical is that some of these networks, particularly the non-canonical networks, are not really familiar to us yet as neurosurgeons. And the software really takes the guesswork out of that by automatically displaying what networks are in play. In this particular case, in insular glioma, we know as neurosurgeons that there are quite a few things in play here. The obvious ones are corticospinal and language. Beyond those traditional networks, I think our understanding of the insula is somewhat limited, and really only a handful of neurosurgeons, I think, doing a lot of insular glioma work routinely could probably get into the nitty-gritty of some of those more complicated networks. And that's where I think the Quicktome really helps to level the field, so to speak. What I want to illustrate specifically here is beyond the corticospinal network and the inferior frontal occipital fasciculus, also known as the IFOF, which I think has become more common knowledge, if you will, among neurosurgeons, is this non-traditional network known as Salience. I could say, having done quite a few insular gliomas, that Salience is not something that I was maybe factoring in enough into my surgical equation, if you will. But as you can see here, as I'm scrolling through the axial projections, and you can see a very obvious insular glioma here, fairly, if not completely, circumscribed to the insula itself, you start seeing some parcellations, one anterior that represents a component of the salience, and now you start seeing on the very lateral aspect of the tumor some additional parcellations that really begin to coalesce as we're traveling along the superior border of the tumor. Now you can see quite a cluster and concentration of parcellations that should give anyone pause, whether it's Salience in this case or any type of network, that with that type of clustering, there's probably going to be some level of significant representation of the network when the density reaches that level. I want to illustrate another projection, the 3D projection, and just to take a very quick step back, you can manipulate axial, sagittal, and coronal projections independently or on this 3D model that you can rotate as I'm doing here. And sometimes a 3D model can put the networks in more perspective. And as I'm scrolling through the sagittal component here, and now you're starting to see the tumor come into the picture, it really, I think, helps to illustrate the density of the parcellations and the networks within Salience along this upper portion of this mass, posterior, and maybe really within some of the mass itself. You could also see in some of the other projections that I was just scrolling through a little bit of temporal extension of the mass, so it's not squarely in the insula as I just described. So what was the impact of this for me? Well, I could say right out of the gate that we were talking about a 72-year-old male who had an isolated seizure. And so my goals of surgery here were a little bit more conservative than, let's say, if this was in someone in their 30s. But what helped refine my surgical approach and technique in this particular case was the knowledge and awareness that this network Salience, which is something that I think many of us have ignored, not volitionally, but just through lack of awareness, was more of a factor in this resection than I had or would customarily anticipate. And the way in which I factored that in was pretty simple in the end. I was just more careful, as it were, in the superior and posterior aspects of this mass. I limited the goals of the surgery in those regions. Again, factoring in the patient's age and the fact that his pre-surgical functional status was excellent, we didn't really want to compromise any type of cognitive processing that Salience is important for. What I have for you now is the same patient's post-operative day 1 MRI. During the operation, which was done awake, the patient did begin to suffer from aphasia. And we had halted the resection at that point. The deficits persisted after the surgery, and I wanted to determine whether or not there was some damage caused to these networks beyond what our traditional post-op MRI would reveal. And what we have here is the axial projection of the Salience network, and you can see as I'm scrolling down through the tumor that we see the parcellations and we see these fibers, but they're scattered, they're disrupted. They're not as organized and as dense as they were on the Quicktome study that we showed just before the surgery. What does this mean? Well, it's tough to draw very firm conclusions, but what I can tell you is that the presence of the parcellations and fibers was suggestive to me of recovery potential, which can make you feel better as a surgeon, obviously, when you've induced a deficit. And more importantly, of course, you can counsel the patient accordingly and forecast recovery. In terms of the duration and extent of recovery, that remains vague. But this is not a circumstance where the Quicktome shows that these parcellations have been cut out or lost. They are there, they've just been disrupted, desegregated, if you will. So that was one of the learning points for me in this case. Even though I was forewarned by Quicktome about the involvement of Salience in this case, I nevertheless induced a deficit for this patient, but then was reassured by Quicktome on the postoperative MRI that parcellations and fibers were present, connoting recovery potential. Lo and behold, at the patient's 1-month postoperative visit, there was significant language recovery. There was also significant cognitive recovery, according to the patient as well as his family, as well as to our speech therapist who evaluated the patient. So hopefully you who are watching this video can appreciate the ways in which Quicktome helped to give us a deeper sense of what was going on with this tumor preoperatively and helped us to evaluate and forecast recovery following the operation. Thank you.